Introduction to Medical Nutrition Therapy, Parenteral Nutrition Part 1. Overview of Parenteral Nutrition. By the end of this section on parenteral nutrition, you will be able to define parenteral nutrition and state its indications for use, differentiate between 2-in-1 and 3-in-1 PN solutions, state how PN is classified and discuss how this influences the type of vascular access device used, and state the two types of infusion modalities. Parenteral nutrition is the intravenous administration of nutrients such as protein, carbohydrates, fats, vitamins, minerals, and electrolytes directly into the systemic circulation, bypassing the gastrointestinal tract. In general, there are two broad categories for which a patient may require parenteral nutrition, which will also be discussed in further detail in the next video in this series. The first category relates to when an individual has a non-functional GI tract. This may occur in the setting of intestinal failure, which is defined as the reduction of gut function below the minimum necessary for the absorption of macronutrients and/or water and electrolytes, such that IV supplementation is required to maintain health and growth. There are a number of other conditions that do not relate to nutrient malabsorption that also warrant the use of PN, such as bowel obstructions or discontinuity or severe paralytic ileus. The second category relates to when an individual cannot meet all of their nutritional needs by enteral nutrition or through an oral diet. Some individuals may be on PN simultaneously with BN or an oral diet. Individuals can also receive all of their nutrition by PN.
In the context of the information we have just discussed, parenteral nutrition is a vital therapy for individuals who are already malnourished or for those who are at a significant risk of worsening nutritional status, such as those receiving perioperative support, patients with GI fistulas or short bowel syndrome, and as previously mentioned, those who are unable to meet their nutrition requirements via other means of nutrition therapies.
PN solutions can provide all nutrients necessary to sustain health, including carbohydrate, fat, protein, electrolytes, vitamins, minerals, and trace elements. The macronutrients, dextrose, amino acids, and lipids are prescribed in different concentrations and volumes depending on the individual's nutrient requirements. Electrolytes can be added according to the patient's requirements. Vitamins, minerals, and trace elements are added as either single entity products or combinations of water and fat-soluble vitamins. And trace elements, which include zinc, copper, manganese, selenium, and chromium, can also be added in concentrations to meet the patient's micronutrient requirements. There are different types of PN solutions. One way they can be categorized is based on how dextrose, amino acids, and lipids are prepared for delivery. A 2-in-1 solution means that 2 bags are hung when providing a patient with all nutrient needs. One bag, the yellow seen on the left, contains dextrose and amino acids, whereas the white bag on the right is the lipid emulsion. In contrast, a 3-in-1 preparation has 3 chambers in one bag, with each chamber containing lipids, dextrose, or amino acids, respectively. This is referred to as total nutrient admixture. As you can see, lipid emulsions are always white in color. PN solutions can be compounded or commercially prepared. Compounded means they are prepared by pharmacy as per the dietitian's prescription. When a hospital has the ability to compound PN, a dietitian can tailor the patient's prescription to be any concentration of dextrose and amino acids, which provide a fair amount of flexibility for PN prescribing. All vitamins, minerals, and trace elements are added by the pharmacist by injecting them into the ports at the bottom of the bag using sterile techniques. In contrast, commercially prepared PN admixtures come ready-made in preset concentrations of dextrose and amino acids, so there is less flexibility for prescribing. Additives like vitamins, minerals, and trace elements are also in these bags. Commercial prepared admixtures come in both 2-in-1 and 3-in-1 preparations. As you can see, these preparations come with each macronutrient sealed in its own chamber. Prior to use, the seals are broken so that the solution is mixed. This is done by gently rolling the bag as per the manufacturer's instructions. It should be noted that depending on a patient's conditions, lipids are not always provided daily, which is an example of when a 2-in-1 commercially prepared solution is used. Compounded PN admixtures are always 2-in-1 with the lipids.
Parenteral nutrition can be classified by the type of vein that is used to deliver the PN solution. The first is the peripheral parenteral nutrition, which is delivered into a smaller peripheral vein. The second is central parenteral nutrition, which is delivered into a central vein. PPN is generally used for short-term periods. The concentration or osmolarity of the PN solution cannot be greater than 900 milliosmoles per liter. Otherwise, complications can occur, which will be discussed in video 4 of this series. This means that individuals with very high nutrient needs or those with fluid restrictions may not be suitable for PPN. It is generally used short-term and is ideal for individuals with lower nutrient requirements or those who do not have central vein access for central PN, which we will discuss shortly.
For the delivery of PPN, it is recommended that peripheral veins in the arms or hands be catheterized, as placing a catheter in these locations is associated with decreased risk of developing thrombosis or sepsis. Peripheral IV or midline catheters, as shown here in the green boxes, are preferred for PPN.
In contrast to PPN, central PN can be used up to any length of time and is also the preferred route for starting PN. As the PN solution is being infused directly into a central vein, individuals with high nutrient requirements or with a fluid restriction can receive CPN.
For the delivery of CPN, various catheters can be used. Usually the type is dependent on the duration of PN. Non-tunnel, non-cuffed central venous catheters, such as those inserted in the internal jugular of subclavian vein, are used for short-term. PICC lines are used for short-term or in the instance where a PICC line is already inserted, which is more likely in certain populations, like the critically ill. An individual can be started on PN via a PICC line. These can be inserted by nurses at the bedside who have specialized training or physicians. The tunneled cuff CVC is for longer-term use, and subcutaneous or implanted ports are for long-term use with intermittent access.
Here we have some examples of what these vascular access sites look like. The internal jugular CVC is used in cases of chronic kidney disease that require dialysis. Subclavian CVC is the favored site for central venous access. These can be placed for a longer-term access, except in the case of chronic kidney disease. Femoral CVC is used in acute or short-term care, or in the event when emergency venous access is needed, like CPR. Typically, use of femoral veins for PN is not recommended due to high risk of infection, thrombosis, and complications with placement. Tunneled CVC is used for longer-term access that can help with patient self-image because it can be hidden by clothing and are less prone to infection. PICC or peripherally inserted central catheter are used in cases where a short to mid-term duration therapy is needed. And implanted ports can be used in cancer cases where intermittent infusion therapy is needed. The type of catheter is not the only consideration when choosing a site, but rather should be a combination of catheter type and the patient's characteristics, preferences, medical history, comorbidities, infusion needs, and the availability of the ports. The goal is to choose a device that is safe, meets the patient's access needs, and is cost effective. The clinician should also consider the type of medication or formulation, the overall therapeutic regimen, the anticipated duration of therapy, the potential impact of the device on the patient's body image, and their activity level. The patient's cognitive ability and willingness to perform the task to maintain their PN at home, should it be required, is also important to assess. There are two main modalities for PN infusions. A continuous infusion rate is when the solution is infused at a constant rate for 24 hours. The individual is connected to the PN pump for the entire day. In contrast, a cyclic infusion is when PN is administered for a specific period of time. It is usually infused overnight while the individual is sleeping. This modality is often used for individuals on long-term PN as it allows them to meet their nutritional needs overnight and gives them freedom from the PN pump during the day. The duration an individual will require PN depends on the individual's previous and current medical condition, their nutrition status and requirements, GI function, and severity of illness. PN can last for as long as needed for the individual. Some individuals are on PN for life, and some only need it for a short period of time. Individuals who require long-term PN can be supported through home PN, which you will hear more about in the next video of this series. In summary, parenteral nutrition is the intravenous administration of nutrients into individuals with a non-functioning GI tract or who cannot meet their nutrition requirements solely by oral diet or EN. PN solutions contain dextrose, amino acids, lipids, vitamins, minerals, and trace elements in the form of compounded or premixed solutions. PN can be infused into peripheral or central veins, and PN can be used for short or long-term durations. Up next, we have part 2 of our 4-part series on parenteral nutrition, indications and contraindications for parenteral nutrition.
Introduction to Medical Nutrition Therapy, Parenteral Nutrition, Part 2, Indications and Contraindications for Parenteral Nutrition. By the end of this section on parenteral nutrition, you will be able to define non-functional gastrointestinal tract, state 2 indications for the different types of parenteral nutrition, state 3 contraindications for parenteral nutrition. We will be following a case study throughout this presentation. Our patient, Robert Smith, has a high-output enterocutaneous fistula, which is an abnormal opening between the skin and GI tract. Fistulas may develop as a result of trauma, surgery, or digestive disorders. As a result of the fistula, the patient has been deemed NPO, which stands for nothing by mouth, for multiple days and is becoming malnourished. This is a common complication of enterocutaneous fistulas. Due to the high output nature of his fistula, enteral nutrition, or tube feeding, is not indicated as it would exacerbate the amount of output from the fistula. And as you can see from the image, fistulas can be quite large openings, and nutrient digestion and absorption would be limited. In Robert's case, goals of care include reducing the fistula output to promote healing and preventing further deterioration of Robert's nutritional status, and in this case, this will be achieved by initiating parenteral nutrition, or PN. We will discuss the indications and contraindications of PN throughout this video to help you understand why starting parenteral nutrition is a life-saving therapy for Robert. The primary indication for PN is a non-functional GI tract, which is the reduction of gut function below the minimum necessary for the absorption of macronutrients and/or water and electrolytes. The majority of digestion and absorption occurs in the small intestine, so if a condition prevents this from occurring, malnutrition is likely to occur. This can be caused by a variety of conditions, such as short bowel syndrome, enterocutaneous fistulas, such as in Robert's case, bowel obstructions, or severe vomiting and diarrhea. Another indication is the inability to meet nutrition requirements orally and/or through EN. This can be due to high nutritional requirements caused by illness or trauma or poor functioning of the GI tract, leading to low absorption of nutrients. PN can be used as a sole source of nutrition, and we can also use PN to supplement an existing nutrition regimen. If the GI tract is functional, we want to use it by feeding orally or via EN to maintain the health of the GI tract and support normal digestive processes. Sometimes the GI tract has only lost some of function, and in these cases, we might try to see if a patient can tolerate an oral diet or enteral nutrition. But if tolerance cannot be demonstrated or the patient is unable to receive 100% of their nutrition requirements, PN must be considered. In most cases, PN should not be prescribed if the anticipated duration is less than 7 days. And finally, nutrition support may not be warranted based on goals of care, such as palliative or end-of-life care. However, these decisions are made on a case-by-case basis and in collaboration with the patient and/or their families.
Recall from part 1 of our parenteral nutrition video series, peripheral PN is administered in a small diameter vein, whereas central PN is administered in a large diameter vein. If a patient is assessed as a candidate for nutrition support and enteral nutrition is contraindicated, for example, due to non-functioning gut or trouble with nutrient absorption or eating enough to sustain nutrition requirements, then we would order parenteral nutrition. If long-term PN use is anticipated or a concentrated solution is needed, central PN will be used. If PN is only required short-term or there is no central access, peripheral PN will be used. Peripheral PN is used for short periods of time, typically less than 14 days, if the patient is reasonably nourished, if there is access to a peripheral vein, and if there is not access to a central vein. Central PN is usually used for long periods of time, but may be used short-term as well. Central PN is also used if the patient has high calorie, nutrient, and electrolyte requirements, or is fluid restricted, or if there is access to a central vein.
Supplemental PN is used when the use of EN or an oral diet is not enough to sustain nutrition requirements. For example, the gastrointestinal tract is functioning but not absorbing well, such as in the case of Crohn's disease or ulcerative colitis, and the patient can tolerate some nutrition orally or via EN, but not enough to meet their calorie and nutrient needs. Supplemental PN in essence means we are simply topping up their nutrition via PN. This will only be done if a person requires PN for more than 4 days. The current recommendations state that if the patient cannot meet 60% of energy and nutrient requirements via EN, supplemental PN should be considered after 7 to 10 days. It is important to note that individuals can be on PN while living at home. Home PN is used for individuals that no longer have to be hospitalized but still cannot meet all of their nutrition needs from oral or enteral routes. This is the primary therapy for those with chronic GI failure, such as short bowel syndrome. Patients are eligible for home PN if their GI tract is non-functioning, they are unable to tolerate oral or EN as their sole source of nutrition because of malabsorption, obstruction, etc., or PN is required for longer durations, but strict hospitalization is no longer needed. In home PN programs, patients are trained how to administer their PN, such as setting up their bags and caring for their lines, so they can be in charge of their own care and have increased freedom. There are 12 home PN programs in Canada. There is only one home PN program in Saskatchewan, which is located in Regina. The other 11 programs are indicated on the map and are located in Vancouver, Calgary, Edmonton, Winnipeg, Hamilton, Toronto, Ottawa, Montreal, which has 2, Quebec City, and Halifax. As part of home PN programs, PN supplies are delivered to the patients for free, and individuals are supported by a multidisciplinary team that typically includes a dietitian, physician, nurse, and pharmacist. Let's return to Robert. We discussed that for Robert, EN is contraindicated and PN is the appropriate choice for nutrition therapy due to the high output nature of his enterocutaneous fistula. Fortunately, Robert has a central line in place and it is appropriate to start him on central PN due to his higher nutritional requirements and the likelihood that he will be on PN for a longer duration. Prior to the use of PN, the mortality rates of individuals with high output enterocutaneous fistulas was 100%. Now, due to parenteral nutrition therapy, mortality rates from fistula have decreased and patients are more likely to experience spontaneous closure of their fistula. In summary, a non-functional GI tract is when gut function is below what is necessary for the absorption of macronutrients and/or water and electrolytes. PN is the primary therapy for individuals with a non-functioning GI tract. PN can be provided as sole source nutrition or supplemental nutrition alongside enteral or an oral diet, and individuals requiring long-term PN can be managed at home. Up next is part 3 of our 4-part series on parenteral nutrition. What is the dietitian's role in formulating a PN prescription?
In part 3 of our parental nutrition video series, we are going to take you through what a dietitian takes into consideration when formulating a parental nutrition prescription. We will then discuss a case study at the end to put everything you've learned together. By the end of this section on parental nutrition, you will be able to describe the dietitian's role in formulating a PN prescription, define refeeding syndrome, and discuss strategies for mitigating the risk of developing refeeding syndrome, and recognize the components of a PN prescription. When a patient requires PN therapy, the first step a dietitian completes is a nutrition assessment. The primary goal of completing this assessment is to determine a patient's overall nutritional health and to determine their nutritional requirements in the context of their disease state or condition. In determining a patient's nutritional health, dietitians consider a patient's food and nutrition-related history. We will look at anthropometric measurements such as weight, as well as biochemical data and medical tests. So, for example, we would want to watch out for indications of hyperglycemia in a patient. Various acute and chronic diseases can cause various fluid needs, which will affect our calculations when deciding on the right PN prescription. We'll also look at patient history as well as their current condition. So, personal, family, and medical history. For example, for medical history, we would be watching out for conditions such as renal failure or diabetes. We will also review the medications they are taking, as some of them can significantly impact a dietitian's PN prescription. And lastly, her current health status, or any new diagnoses, such as developing enterocutaneous fistula, where the patient may be losing fluids and electrolytes. In order to determine nutritional requirements, dietitians follow clinical practice guidelines and expert consensus recommendations for varying disease states and conditions. So, for example, here at the top, we have a practice guideline for nutritional management of individuals with chronic intestinal failure. On the bottom, we have critical practice guidelines for nutrition support for critically ill patients and for patients with enterocutaneous fistula.
Another important part of our nutritional assessment, particularly for individuals starting nutrition support, is identifying whether a patient is at risk of developing refeeding syndrome, which is defined as the potentially fatal shifts in fluid and electrolytes that may occur in malnourished patients, those who have been chronically or acutely starved, or patients recovering from severe catabolic diseases after the start of nutritional therapy. Although severely malnourished patients are at the highest risk of refeeding syndrome, other populations who are at risk include patients with malabsorptive syndromes, such as inflammatory bowel disease, patients with anorexia nervosa, those with a recent history of bariatric surgeries, individuals with chronic and excessive alcohol or drug use, critically ill patients, those with low baseline serum magnesium, potassium, or phosphate concentrations, malnourished patients with cancer, those with GI fistulas, and geriatric patients. The purpose of this slide is to provide an overview of the metabolic processes that drive refeeding syndrome and the possible catastrophic consequences that can result from it. The underlying causative factor of refeeding syndrome is the metabolic and hormonal changes caused by rapid refeeding, whether oral, enteral, or parenteral. In early starvation, the body switches from using carbohydrate to using fat and protein as the main source of energy, and the basal metabolic rate decreases by as much as 20 to 25%. During prolonged fasting, hormonal and metabolic changes are aimed at preventing protein and muscle breakdown. Muscle and other tissues use fatty acids as the main energy source. During the period of prolonged starvation, vitamin and mineral stores become depleted, as do several intracellular minerals. However, serum concentrations of these minerals, including potassium, phosphate, and magnesium, may remain normal. This is because these electrolytes are mainly in the intracellular compartment, which contracts during starvation. When an individual is aggressively fed after a period of starvation, the blood glucose levels increase, which leads to increased insulin production. Insulin stimulates glycogen, fat, and protein synthesis, and a rapid increase in basal metabolic rate is seen. These metabolic processes require minerals such as phosphate and magnesium, and cofactors such as thiamine. Insulin stimulates the absorption of potassium into the cells through the sodium-potassium ATPase symporter, which also transports glucose into the cells. Magnesium and phosphate are also taken up into the cells. Water follows by osmosis. These processes result in a decrease in the serum levels of phosphate, potassium, and magnesium, all of which are already depleted. Changes in carbohydrate metabolism also have a profound effect on sodium and water balance. The introduction of carbohydrate to a diet leads to a rapid decrease in renal excretion of sodium and water. If fluid repletion is then instituted to maintain a normal urine output, patients may rapidly develop fluid overload. The clinical features of refeeding syndrome occurring as a result of the functional deficits of these electrolytes, the rapid change in basal metabolic rate, and the dysregulation of fluid homeostasis include increased heart and respiratory rates, pulmonary edema, and in the case of an individual with extreme starvation who is rapidly refed without mitigation of risk of refeeding, even death can occur. Fortunately, refeeding syndrome is entirely preventable, and several practice guidelines and algorithms have been developed to guide clinicians in providing nutrition support, including parenteral nutrition, in a way such that it is done safely and prevents or reduces the risk of refeeding syndrome from occurring. These guidelines also serve to guide clinicians in the management of refeeding syndrome if a patient is showing signs and symptoms. As you will see, the prevention and management of refeeding syndrome is a multidisciplinary affair. The prevention of refeeding syndrome requires a coordinated effort from the multidisciplinary team. The first step the team must take is to identify whether a patient is at risk of refeeding syndrome as per the general criteria we previously outlined. If it is determined that the patient is at risk, then the following actions must be taken prior to and during the initiation of nutrition support, whether it be enteral or parenteral nutrition, or even an oral diet. Fluid balance needs to be assessed to determine the patient's fluid requirements to ensure fluid overload is avoided. Blood work, including making sure that potassium, phosphorus, and magnesium are ordered, must be done before nutrition support is started and subsequently corrected for via IV supplementation. Due to the metabolic nature of refeeding syndrome, as previously discussed, thiamine could be depleted, so the patient might be an appropriate candidate for short-term thiamine supplementation as well. It should be noted that these electrolytes do not need to be corrected before feeding is initiated and can happen concurrently with the initiation of nutrition support. In the setting of the delivery of parenteral nutrition, correcting for electrolytes before or during the delivery of PN must never be done through the PN solution, but rather individuals should be given separate IV infusions of electrolytes as required. From a nutrition perspective, the dietitian will determine what the patient's target nutritional requirements are. However, one of the most crucial aspects of reducing the risk of refeeding syndrome occurring is to start PN slowly, meaning that the amount of PN solution provided might be as low as 20% of their estimated calorie target. The higher the risk of refeeding a patient is, and this is easily determined by a dietitian, the lower the amount of calories will be given. On the other hand, if a patient is not deemed at risk for refeeding syndrome, enteral feeding can be initiated as per standard protocols as per the dietitian's recommendation.
In addition to a nutrition assessment and determining the risk for refeeding syndrome in prescribing PN, another factor that a dietitian takes into consideration is whether peripheral parenteral nutrition or central parenteral nutrition is appropriate for the patient. Recall from the first video of this educational series on PN that peripheral PN is when the PN solution is delivered into a peripheral vein and is used typically for short-term access or when a central line is not accessible, but cannot be used to provide the full nutrient needs of someone with higher nutrition requirements due to limitations on concentration of the PN solution that can be delivered. In contrast, central PN is when the PN solution is delivered into the central vein, and this type of PN can provide an individual with all their nutrition requirements. Once the type of PN has been determined, a dietitian will assess whether a patient has the appropriate vascular access line or device in place. If not, the dietitian will communicate with the multidisciplinary team, and a physician can order the insertion of the appropriate IV catheter. For individuals in the intensive care unit, dietitians will always identify whether a patient is receiving the sedative propofol before determining whether a parenteral or enteral nutrition prescription is needed. The reason for this is that propofol is suspended in a 10% lipid emulsion, and depending on the rate propofol is being infused, can provide a significant amount of calories to the patient. Thus, if a patient is on propofol, the dietitian will determine how many calories the propofol provides and subsequently adjust the nutrition prescription to accommodate for these calories. For example, if we determine an individual's energy requirement to be 1800 kcal, but the patient is receiving 300 kcal for propofol, we will tailor our nutrition prescription to provide only 1500 kcal. From a parenteral nutrition perspective, if we have a patient on propofol, this is an excellent example of when we would use a 2-in-1 PN solution, which was introduced in the first video of this series. Contains only dextrose and amino acids versus a 3-in-1 solution that also contains lipids.
After collecting all of the necessary assessment parameters we have reviewed, one of the final steps the dietitian takes in determining a PN prescription is to first determine how many calories and grams of protein, fat, and carbohydrate a patient requires to support their nutritional health and current condition. As we've previously mentioned, we typically rely on clinical practice guidelines to determine our patient's requirements. This slide provides a nice summary of different guidelines of how much we would provide someone based on their condition. For example, if you refer to the red box, a stable patient requires approximately 0.8 to 1.5 grams of amino acids per kilogram of their body weight per day, whereas a critically ill patient has considerably higher amino acid requirements, and thus it's recommended they receive 1.2 to 2.5 grams per kilogram per day. Something else that a dietitian needs to consider when formulating their final PN prescription is how much carbohydrate is being infused on a per minute basis, as infusing greater than 4 to 5 milligrams dextrose per kilogram per minute will exceed the maximum amount of dextrose the liver can oxidize, resulting in hyperglycemia and other complications. Similarly, we need to ensure the amount of lipid we prescribe does not exceed 1 gram of lipid per kilogram body weight per day to minimize the risk of hypertriglyceridemia, infectious complications, and fat overload syndrome.
PN bags also include additives, which include vitamins, minerals, trace elements, and electrolytes. Pre-made PN bags often already have these elements added into them at standard amounts. Physicians or dietitians with advanced training can prescribe the dose of additives the patient requires. It is important to note that when a patient is acutely ill and not stabilized and has low electrolytes, these should always be corrected through separate IV supplementation and not via parenteral nutrition, as a parenteral nutrition solution is hung over a 24-hour period, and correcting electrolytes through PN can put a patient at risk of getting excessive and unsafe amounts and being overcorrected. Lastly, a dietitian will determine if the patient should be on a continuous or cyclic infusion based on a variety of factors. Some examples of why a dietitian would put a patient on cyclic infusion include if the patient is stable on their PN, if the patient wants more flexibility in their life to do activities during the daytime, and if the patient is going to be doing long-term PN at home. It is also important to note that a patient should not be transitioned to a cyclic infusion if they have unstable blood glucose, as starting and stopping PN could lead to hyper or hypoglycemia. As was discussed in the first video of this series, PN solutions come in different concentrations or strengths. Thus, once a dietitian has determined the patient's calorie and macronutrient requirements, we can then determine the volume and concentration of dextrose, amino acid, and lipid solution required. Once we know the final volume, we can then translate this into an infusion rate depending on whether the patient is appropriate for continuous or cyclic infusions. Here we have an example of what a 2-in-1 plus lipid prescription would look like. This is a generic prescription, and it is important to note that hospitals typically have standard order sets for PN, which this information would be written on. The order sets also include a space to denote the additives you would like to include in the solution. The first part of the prescription states the concentration of 2-in-1 solution. so the concentration of dextrose and amino acid solutions in the PN bag and the rate this would be infused at. The second half of the equation is the lipid component, thus stating the concentration of lipid and rate it should be infused. It should be noted that there are various types and brands of lipids, so typically the concentration and then the brand name, example intralipid, is stated. In the previous video of this parenteral nutrition series, a case study was introduced in which we learned that our patient now has an enterocutaneous fistula and central PN has been indicated. As our patient is critically ill, we referred to guidelines for the provision of nutrition in the critically ill patient, but also reviewed guidelines for nutrition therapy for patients with an enterocutaneous fistula, which allowed us to determine their calorie requirements, as well as the grams of dextrose, amino acid, and lipids they require to maintain their nutritional status. In completing our assessment, we note that our patient was receiving propofol, which remember is a sedative suspended in a lipid emulsion. We identify that this patient is receiving a high volume of propofol and in fact is receiving all their lipid requirements from propofol, so we do not need to provide them with additional lipid via PN. Because of this, we would choose a 2-in-1 solution as our patient only needs dextrose and amino acids while they are on propofol. Thus, we proceed to calculate the concentration of dextrose and amino acid solution that will meet our patient's requirements in a volume that is appropriate for their fluid needs. Here we have our final prescription for our patient. For our patient, he is able to start PN at the goal rate of 70 milliliters per hour because he was deemed to be not at risk as he was receiving enteral nutrition continuously prior to developing the enterocutaneous fistula. We will continue to monitor him, which will be reviewed in depth in the next video of this series. It is important to note that propofol doses change frequently and it will eventually be discontinued, so a dietitian will continue to adjust the PN prescription as the propofol dose is changed. When a patient's propofol is discontinued, at that point we will reassess the prescription and add lipids, which could either be in the form of a 2-in-1 plus lipids or a 3-in-1 if appropriate.
To summarize everything discussed here, parenteral nutrition prescriptions are individualized, encompassing varying factors. There are clinical practice guidelines that are used for decision-making for nutritional requirements. Refeeding syndrome must be taken into consideration when starting parenteral nutrition. And patients can receive energy from other places other than parenteral nutrition, which is why you must consider patient medications such as propofol. Up next is part 4 of our 4-part series on parenteral nutrition. Stay tuned for monitoring and complications of parenteral nutrition.
Introduction to Medical Nutrition Therapy, Parenteral Nutrition, Part 4, Monitoring and Complications of Parenteral Nutrition. By the end of this section on parenteral nutrition, you will be able to describe how tolerance to parenteral nutrition is monitored, report on the short and long-term complications associated with PN, and discuss strategies to manage these complications. Determine how to assess patient readiness for the transition from PN to an oral diet or enteral nutrition, and when PN can be safely discontinued. In the previous videos of this educational series, you were introduced to our case study patient who had developed an enterocutaneous fistula and was subsequently started on central PN as per the dietitian's prescription, which you can see has been started in the pink circle. It is important to review the role of the multidisciplinary team in the delivery of parenteral nutrition. As you have seen, the dietitian determines the PN prescription. However, the determination for the need for PN is usually discussed with a physician and a dietitian. In some jurisdictions, a dietitian can sign off on orders to start PN as their prescription, while in others, a physician must review the order and sign off. Physicians order insertion of IV lines or vascular access devices, and these can be inserted by physicians or nurses with specialized training. Once PN has been prescribed, a pharmacist will check the PN prescription for compatibility and solubility, with a specific focus on ensuring the solubility of the additives and physical compatibility of parenteral medications given via Y-site administration. The pharmacist also prepares compounds for the PN, and a primary responsibility is to ensure that the PN is prepared safely, free of microbial and particulate matter. Once the PN solutions are prepared, the nurse is responsible for the delivery of the PN solution to the patient. Once PN is initiated, the next step is to monitor for tolerance, watch for any PN-associated complications, and determine the effectiveness of the PN therapy.
One of the primary parameters we look to when monitoring PN is blood work. The frequency of monitoring blood work depends on the severity of the illness, metabolic stress, and other clinical conditions of the patient. PN monitoring is also hospital-specific. For example, the standardized PN order sets that have been developed for hospitals in the Regina-Coppell Health Region automatically trigger orders for PN blood work, which is shown in the image here. As you can see, a number of panels are run, including CBC, chemistry, liver, and renal panels, electrolytes, and serum triglycerides as well. In severely malnourished or long-term PN patients, vitamin and trace elements should be monitored regularly. When monitoring blood work, it is important to look out for any abnormal shifts in electrolyte balance or the presence of hyperglycemia, hypoglycemia, hypertriglyceridemia, and refeeding syndrome. It is suggested to monitor blood work before PN starts, and also during PN treatment on days 1, 2, and 3, and then biweekly after that. Serum glucose should also be monitored 4 times a day for 48 hours after starting PN, and after that, monitoring can be done as needed. Serum glucose is important to be monitored because patients who start PN are at an increased risk of hyper and hypoglycemia. Fluid balance is also important to monitor because it is possible for fluid overload to occur when the infusion rate is going faster than the body can process. As was briefly alluded to in the last video, PN should never be used to treat electrolyte or acid-base imbalances in individuals who are acutely ill or medically unstable. This is because PN usually infuses over 24 hours, and if the concentration of an electrolyte is increased in the PN solution, there is a significant risk of overcorrecting, which could result in significant medical complications. Instead, electrolyte abnormalities can be made with supplemental electrolytes as appropriate. PN adjustment should only occur in a long-term setting if someone has chronically low or elevated electrolytes. As with any type of drug therapy, the delivery of PN can result in short and long-term complications. When we refer to short-term complications, we are referring to complications that can occur right after administration of PN.
If you recall from our previous videos, one type of PN is peripheral PN, in which PN is delivered into a small peripheral vein. As was discussed, when an individual is on peripheral PN, the concentration of PN solution cannot be greater than 900 milliosmoles per liter, which means that highly concentrated PN solutions that are required for individuals with larger nutrition requirements are not appropriate to be delivered via a peripheral line. One complication associated with peripheral venous catheters is infusion phlebitis, as seen here. The symptoms include pain, erythema, tenderness, or palpable cord. The risk of infusion phlebitis depends on catheter material and size, clinician skill, type of infusate, and cannulation duration. The CDC recommends rotating insertion sites every 72 to 96 hours to reduce the risk of phlebitis. Removal of the catheter should occur immediately when phlebitis is observed. Possible complications associated with central venous access devices include CLAPSY, central line bloodstream infection, and deep vein thrombosis. These complications may lead to sepsis or pulmonary embolisms and complicates the success of PN therapy in the long run. If we come back to our case study patient, he was deemed to be at low risk for refeeding syndrome at the time of PN initiation. Blood work on day 1 post-PN initiation came back. In reviewing the labs for the 3 electrolytes that will commonly decrease in the setting of refeeding syndrome, we see that potassium and phosphorus are mildly low, whereas magnesium is within normal limits. Given the patient's overall medical status, it is difficult to say whether this patient is in refeeding syndrome, but it cannot be ruled out. It is important that we continue to monitor other factors associated with refeeding syndrome complications, including a patient's fluid balance and vital signs. Common clinical symptoms of refeeding syndrome are tachycardia, tachypnea, and with severe refeeding, pulmonary edema. Once a patient is identified as showing signs and symptoms of refeeding syndrome, it must be managed. Refeeding syndrome is preventable, and awareness of who is at risk and quick recognition is part of preventing serious complications of refeeding syndrome. A solid multidisciplinary team, including physicians, dietitians, nurses, and pharmacists, is critical to maintaining patient safety. When PN is initiated, if there are no signs or symptoms, including refeeding syndrome, no modification to the EN therapy is required. In contrast, if a patient is showing signs and symptoms of refeeding, which is identified by monitoring the parameters listed, the following treatment strategies are suggested. A zero fluid balance must be maintained, which may require adjusting fluid from IV or EN. Electrolytes should be corrected by supplementation as necessary, and patients should also be supplemented with thiamine and a multivitamin/mineral, as thiamine is typically depleted if refeeding occurs. Cardiac function must be monitored regularly, and the nutrition prescription must be modified, such as reducing the rate of EN infusion if it was started too high and ensuring minimal fluid is given to maintain a zero fluid balance. As you can see, the management of refeeding syndrome is a multidisciplinary effort that requires a coordinated response from the multidisciplinary team. In the case of our patient, the only signs of possible refeeding were a mild drop in potassium and phosphorus, so in this case, the patient should be given IV potassium and phosphorus supplementation, and we should ensure that we are maintaining a zero fluid balance. Given the patient was only showing mild signs of refeeding, and we are correcting the electrolyte abnormalities, the PN can continue to infuse at goal rate, and we will continue with our ongoing monitoring.
Hyperglycemia and hypoglycemia can occur in individuals receiving PN. Hyperglycemia can be caused by excessive dextrose from PN, steroids, or stress. It is important to emphasize here that PN is not always the cause of hyperglycemia in a patient receiving PN therapy, and it can often be related to multiple factors. If hypoglycemia occurs, this could be due to receiving excessive insulin intravenously through insulin therapy or abrupt discontinuation of PN for those with PN at home. If you remember from the PN blood work monitoring order set, triglycerides are measured frequently in individuals on PN. This is because triglycerides can increase relatively quickly in the setting of excess dextrose or lipids being infused. To treat hyperglycemia, the dietitian can reevaluate the PN prescription to decrease the amount of dextrose being delivered or decrease the dextrose infusion rate. Additionally, the patient should be started on a sliding scale insulin protocol or an insulin infusion, whichever is appropriate. This is ordered by the physician. Sometimes, standard PN order sets include an insulin protocol. It is typically not advised that insulin is added to the PN solution, especially because this can result in hypoglycemia. To treat hypoglycemia, a dextrose 10% infusion can be given. An insulin administration should be stopped if it is currently being infused. Both are ordered by the physician. Triglycerides should be reviewed weekly because of the many susceptible complications that occur with high levels of triglycerides. When this happens, a dietitian can adjust the PN prescription such that only the minimal amount of lipid required to prevent fatty acid deficiency is given, and is done so once per week. Another adjustment that can be made to the PN prescription that the dietitian can make is to reduce the dextrose load given.
Individuals who require longer-term PN, especially those on home PN, are susceptible to a variety of unique complications. Metabolic bone disease can entail the presence of osteoporosis, osteomalacia, osteopenia, or a combination of all three. The prevalence of PN-associated metabolic bone disease is unknown. Many diseases, conditions, and medications are associated with bone loss, and all long-term PN patients manifest or have at least one of these factors. Therefore, it is difficult to conclude whether PN directly contributes to bone loss. A study reports that osteoporosis was seen after at least 6 months in patients on home PN. Bone disease can lead to serum alkaline phosphatase, hypercalciuria, bone pain, and fractures. Screening processes should be in place to identify any patients at risk for metabolic bone disease. A baseline dual energy X-ray absorptiometry scan, or DEXA, measures bone density. A DEXA should be done for all patients who are on long-term PN. There are common electrolytes of concern when monitoring for bone disease, which include the lowering levels of calcium, vitamin D, phosphate, and magnesium. There are notable concerns for a negative calcium balance because increased urinary calcium loss can occur from many factors. Having a limited physical compatibility of the calcium supplementation and PN formulation, having higher calcium doses, higher protein doses, having a low phosphorus intake, and also having a cycling PN infusion rather than a continuous infusion can all increase urinary calcium losses. For magnesium, having hypocalcemia can be a significant manifestation of magnesium deficiency. Low vitamin D levels can also lead to bone disease. Therefore, these electrolytes are important to monitor, and low levels may exacerbate the disease. Treatment for metabolic bone disease can include PN modifications if deemed appropriate, and working with the healthcare team will be vital in determining strategies to help decrease symptoms and the progression of the disease.
Hepatobiliary complications can be referred to as IFALD, intestinal failure-associated liver disease, or PNALD, parenteral nutrition-associated liver disease. Both terms are interchangeable and refer to hepatobiliary complications associated with PN. These complications can lead to cirrhosis, portal hypertension, or end-stage liver disease if not treated or monitored. Liver steatosis is a frequent complication in home PN. Steatosis can develop due to overfeeding of glucose. The excessive energy stimulates insulin release and inhibits fatty acid oxidation. Therefore, little to no fat is broken down. TPN can lead to gallbladder stasis, which can create gallbladder sludge and stones. The treatment for gallbladder stones and sludge is CCK, or cholecystokinin, which can help stimulate gallbladder contraction. Small amounts of EN or oral intake can also stimulate the gallbladder and prevent gallbladder sludge and stones. ILEs are injectable lipids that are a source of essential fatty acids for those on PN. Regarding hepatobiliary complications, soybean ILEs tend to be the culprit. Soybean oil-based ILE contains high amounts of omega-6s and a significant amount of phytosterols. Phytosterols are metabolized as bile acid by the liver. Because of this, they can impair bile flow and cause biliary sludge and stones. Also, the omega-6s in the soybean ILE may worsen inflammatory states. The phytosterols and omega-6s can contribute to hepatotoxic effects for those receiving long-term PN. Therefore, switching to an ILE that is a fish oil-based, primarily made of omega-3s and has no phytosterols may be best. Regular monitoring of blood work, including a liver panel, is vital to prevent hepatobiliary complications. Our goal is to prevent overfeeding of macronutrients by decreasing dextrose and lipid intake, specifically, which means we must monitor blood work and is why order sets, like the one shown, recommend routine labs taken daily for the first 3 days following PN initiation, and then continue to be taken twice per week, once for monitoring for longer-term complications. Overall, the intervention of hepatobiliary complications includes the limitation of soybean-based IV lipids, which can cause complications when used in excess. For those who are on the home PN, transitioning to cyclical PN can help to prevent hepatobiliary complications.
Many patients started on PN for various reasons you learned about in the second video of this series will not be on PN forever if the medical issue that necessitated PN in the first place is resolved. Thus, it is important that we discuss how we can transition a patient off PN and back to either an oral diet or enteral nutrition. An important aspect of monitoring a patient on PN is evaluating when and if the patient can be transitioned off PN. Some important considerations include GI function, nutrition status, aspiration risk, and the patient's engagement or willingness level. An indication that the gut is beginning to function normally is a return or an improvement in the patient's bowel movement. Keep in mind that patient can still be receiving PN and oral nutrition simultaneously. A general guideline is that PN is continued until the patient is consistently receiving at least 50 to 75% of energy and protein orally or through EN and is demonstrating signs of improvement. If transitioning to EN, we want to ensure that the patient is tolerating EN or oral intake before decreasing the PN infusion or discontinuing it altogether. Coming back to our case study, fortunately, the fistula has healed up nicely. Thus, we are able to assess the readiness for transition to an oral or EN diet. The plan will be to first decrease the PN such that the infusion rate is providing the patient with about 75% of the required calories. In this case, the patient is intubated in the ICU, thus we are transitioning to enteral nutrition, which we will slowly initiate by starting at a rate that provides about 25% of their nutritional requirement. During this transition, we will monitor EN tolerance, as you were taught in the 4th video of the enteral nutrition video series, including continued assessment of blood work and monitoring of GI symptoms. If the patient is showing signs of tolerating EN well, we can slowly increase EN toward the patient's goal rate, which provides all of their nutritional needs while simultaneously decreasing the PN infusion rate with the goal of eventually weaning the patient off of PN. If our case study patient was extubated, alert, oriented, and was deemed safe to start an oral diet, the same principle would apply, and whatever form of nutrition support they are receiving will be slowly titrated down while oral foods are introduced. And once a patient demonstrates that they can consume about 75% of nutrition requirements, only then should nutrition support be stopped. It is vital that we do not abruptly stop nutrition support until we know an individual can tolerate or consume adequate nutrition. Otherwise, we are putting the patient at significant risk of malnutrition, which will complicate their journey to recovery.
In summary, comprehensive blood work is a hallmark parameter we rely on to monitor tolerance to PN and identify PN-associated complications. Short-term complications of PN include hypoglycemia, and hypertriglyceridemia, which can be managed by adjusting the PN prescription in combination with medical management. Long-term PN is associated with metabolic bone disease and hepatobiliary complications. As individuals recover and can transition off of PN and onto EN or an oral diet, they must be slowly weaned off of the primary route of nutrition delivery at the same rate the new route of delivery is being titrated up. Only when a patient is tolerating an EN infusion rate that is equivalent to 75% of their nutrition requirements or are consuming 75% of their nutrition requirements orally can PN be discontinued. Thank you for your participation with our video and the previous videos on the subject of EN and PN. We hope the information presented increases your understanding on the topic and in your future careers.